All. This is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. My apologies to start a little earlier today. I have to go for an appointment. So this study is really interesting, published in the Lancet March 14, 2024, this year. And what it shows is that in COVID-19 infected patients who have just started having symptoms, if within 48 hours, these patients are given early treatment, then their clinical deterioration is stalled or likelihood of deterioration is significantly reduced. So let's look at this study. I'm not going to go into the mechanisms of all the drugs involved because that would take a lot of time. I want to have you look at the study and the results first. So maybe then we would do a follow-up with the study and the mechanisms. So this is Drbeen.com. If you go to Drbeen.com/med-nerd, you will come across this excellent offer. For a cup of coffee a month, you can get access to all the medical lectures on Drbeen.com. So that is one. Take advantage of that. Here is the study. The study is published in eClinical Medicine, the Lancet. It is March 14, 2024. When it is published, it says early treatment with fluvoxamine, bromhexin, cyproheptadine, and nicotinamide to prevent clinical deterioration in patients with symptomatic COVID-19, a randomized clinical trial. Beautiful study. We should have been looking for this study for a long time ago. And now, before we continue, look at this set of authors and researchers who took part in it. This is a study, I believe, from Thailand. However, a couple of things to note. Number one, Dr. Farid Jalali. You would actually see his interview on my channel, I think 2 years ago, where he was talking about the serotonin bradykinin storm, and he was offering some drugs to be used. Those drugs are used here in this study. So Dr. Farid Jalali, wherever he is, and whenever he would suggest something, I would always take it. I trust him so much. The second one, which is important to keep in mind, is Angela M. Rearson, supervision, conceptual investigation, data curation, etc. She is also, if you look at the declaration, Dr. Rearson is listed as an inventor on a patent application related to methods of treating of COVID-19, including sigma-1 agonists and specifically fluvoxamine. Fluvoxamine is part of this discussion today as well, which was filed by Washington University in St. Louis. So just be aware that there is one author who has a patent on fluvoxamine to treat COVID-19. So these two authors, very important. And I am grateful to Jean for helping me review and understand some of these parts of the study. Okay. Now, there is some more data in here. There is a link for additional data, which has protocol and statistical analysis plan. This is also very interesting to see. Exclusion criteria is more interesting. Because fluvoxamine was involved, they were very careful for who is part of it. The population that took part in the study was 18 to 60. This was the population where they were expecting people not to deteriorate too much. So rather healthy population. However, still there was a control group and there was a intervention group. And in the intervention group, they gave various combinations of drugs. So even when the groups were rather healthy, they were similar groups on both sides. And when you would look at this study with me, you would see that the control group, the standard of care group, deteriorated, while the group that were placed on the drug interventions, early drug interventions within 48 hours of start of COVID or start of the symptoms of COVID, they did very well. So it is not that they did very well because they were healthy and the control group was not healthy. The groups were similar. It's just that they were on these drugs. So some more links over here. This is very, very interesting to look at the actual protocol and the drugs used and how they were used and what were the exclusion criteria. This is also the PDF of the same. And then in the description of this video, there is a link to Dr. Bean merchandise. I have just printed, I drew this one last week. So this is for the vaccine side effect patients and the long COVID patients. It says, my monocytes are immortal, ask me why. So it allows you to have that discussion that your monocytes in the long COVID, some long COVID patients, some vaccine side effect patients who have long COVID-like symptoms, the monocytes become non-classical and intermediate monocytes. They become active with carrying S1 protein or mutant S1 or S2 pieces. These monocytes can then bind with the endothelium, cause inflammation of the endothelium, and clotting and vascular problems can occur. And interestingly, when these monocytes bind with the endothelium, fractalkine molecules on the endothelium, the monocytes have an internal protein, BCL2, that becomes active. And that BCL2 activity makes the monocytes immortal, or they do not die, they do not do apoptosis anymore, and they just stay active. So if you would like to buy a mug or any of these merchandise, feel free to. And finally, before we look at the study, I want to show you one more thing. So this is the channel which you are watching right now. And in this channel, if you go and look for example, fluvoxamine, I just came with receipts. I had been talking about fluvoxamine 2 years or more ago in context of the COVID-19. I believe I was the first who discussed the study that came out for fluvoxamine and COVID-19. I was the first to present that. And then after that, many folks actually started using fluvoxamine. So I had discussed it 2 years ago. Similarly, cyproheptadine, nicotinamide, bromhexine, I had talked them years ago. Even Dr. Fareed Jalali, if you search for the word Dr. Fareed Jalali, you would see his interview here as well somewhere with him talking about the bradykinin storm. It's an excellent interview to watch. Okay, so with all of this, let's go to the actual talk. And my apologies, I was early today. Instead of 6 o'clock, I had to go somewhere. Here is the background. Repurposed drugs with host-directed antiviral and immunomodulatory properties have shown promise in the treatment of COVID-19. So just very quickly, overall, fluvoxamine is a sigma-1 antagonist. It is selective serotonin reuptake inhibitor. That is why fluvoxamine has to be taken with a lot of caution with your doctor's help. Now, usually fluvoxamine is taken for psychiatric needs, and it is taken for more than 2 weeks. However, in the case of COVID studies, the fluvoxamine has shown to be effective within 1 week or about 10 days or so, and at a lower dose, even 10 milligram instead of 50 milligram. So this molecule has a different effect for COVID compared to psychiatric needs. Then bromhexine. Bromhexine is a drug that is a mucolytic. It breaks down the mucus that develops when we are infected. Cyproheptadine is an H1 blocker, so histamine blocker, plus it is a 5-hydroxytryptamine or serotonin receptor blocker as well. So very interesting drug. And nicotinamide, it blocks the glucose channels in the worms in our intestine and kind of causes the worms to die, just similar like ivermectin is. However, nicotinamide molecule has its own effect on COVID and SARS-CoV-2 as well. And the authors have actually given a table separately where they have discussed the mechanism. So I believe down here in this document, they have discussed and drawn the potential mechanism here. So they have drawn potential mechanisms, and this diagram kind of alludes to that Dr. Fareed Jalali may have something to do with this one because it looks like his kind of diagram. Okay, so with this background, Repurposed drugs. The aim of this trial was to assess the effectiveness of affordable, widely available repurposed drugs used in combination for treatment of COVID-19, which may be particularly relevant to low resources countries. Method. We conducted an open label. So the patient knew, the doctor knew, open label randomized outpatient control trial. So this was not in very sick patients. This was in outpatient patients. Controlled trial in Thailand from October 1, 2021 to June 21, 2022. To assess what early treatment within 48 hours of symptoms onset with combination of fluvoxamine, bromhexin, cyproheptadine, and nicotinamide given to adults with confirmed mild SARS-CoV-2 infection can prevent 28-day clinical deterioration compared to standard of care or standard care. When I looked at this study, let's assume for a second that study is good and solid. Then the message is that if we had been using this type of intervention early on, we would have saved a lot of people. Anyways, we would continue to review the study, we'll critique the study, we'll see the strengths and weaknesses of it, and then we'll make another run on this study's details. But I just wanted to make you aware of this one. Participants were randomly assigned to receive treatment with fluvoxamine alone, and fluvoxamine alone did not do very well as compared to the combinations. So fluvoxamine alone, fluvoxamine plus bromhexin, fluvoxamine plus cyproheptadine, nicotinamide plus bromhexin, or standard care. The primary outcome measured was clinical deterioration within 9, 14, or 28 days using a 6-point ordinal scale. So now I'm going to increase the size so we can read this together. Among 1900, so when I'm going to read the findings to you, please note something. Patients of standard of care, remember a little about when we were going through the COVID time, the chaos and the scare and the destruction that was occurring. People were ending up in the hospitals. Then out of them, there were some that would end up in the ICU. Out of those who are in the ICU would end up on the ventilators, and some of them would die. That was what we were observing. You would see here two groups of patients, those on standard care and those on interventions. You would see that the intervention group would kind of cruise along the symptoms fine, while the standard care patients, when I'll read their data and their findings, they would look exactly like what we had been observing. The chaos and destruction, you would see that. So among 1,900 recruited, a total of 995 participants completed the trial. No participants had clinical deterioration by day 9, 14, or 28 days among those treated with fluvoxamine plus bromhexin. So no, the green part I'm reading, no participants had clinical deterioration by day 9, 14, or 28. When they were treated with fluvoxamine plus bromhexin, 0%, fluvoxamine plus cyproheptadine, 0%, nicotinamide plus bromhexin, 0%. So when you read this green part, intervention part, it seems like patients developed COVID. Within 48 hours, they got these drugs and nothing happened. They were fine. They recovered. 9 participants, 5.6% in the fluvoxamine arm. So this was fluvoxamine alone. 9 participants in the fluvoxamine arm had clinical deterioration by day 28, requiring low flow oxygen. So fluvoxamine alone still was not as robust as the combinations. Now I'm going to read the standard care and just visualize those destructions that we had seen and visualize and hear what happened to this group. In contrast, most standard care arm participants had clinical deterioration by 9, 14, and 28 days. By day 9, 32.7% or 110 of patients in the standard care arm had been hospitalized without requiring supplemental oxygen, but needing ongoing medical care. Just like we were going through the COVID and some of us would end up in the hospitals. By day 28, this percentage increased to 37.5%. Another 21 patients got added to this group. Additionally, 20.8% of patients in the standard care arm required low flow oxygen by day 9. Remember, we used to talk about it that out of 100 patients, 20 would end up in the hospitals needing oxygen. Out of those, 5 or 6 would end up in the in the ICU and the ventilators, and 3 or 4 would die. This is the same exact pattern that we are seeing. But they were very similar to the other group who were on the intervention, and in the intervention, nothing happened. So additionally, 20.8% of patients in the standard care arm required low flow oxygen by day 9, and 12.5%, 16, needed non-invasive mechanical ventilation by day 28. This is what was happening to standard care. All treated groups significantly differed from the standard care group by day 9, 14, and 28. P-value is 0.0001. Also, by day 28, the 2 drug treatments were significantly better than fluvoxamine arm alone. That is also significant p-value. Now, this is important. No deaths occurred in any study group, standard care or others. They were all outpatient patients, so that means they were rather stable. They had infection, they had symptoms, but they were not deteriorating. The exclusion criteria were such, the age groups were such, but still within the comparison of these 2 groups, intervention did better. No deaths occurred. And this is something that keep in mind. Again, Jean helped me keep this in my mind as well, that in their findings, they kind of make a statement that is kind of a little loose statement. So we'll go there. So keep in mind that no deaths occurred in any of the groups. No deaths occurred in any study group. Compared to standard care, participants treated with combination agents had significantly decreased viral load as early as day 3 of treatment. 3rd day of treatment, viral load was reduced compared to standard care. Decreased levels of serum cytokine interleukin 6. Remember interleukin 6, the cytokine storms? So interleukin 6, tumor necrosis factor alpha, and interleukin 1 beta as early as day 5 of the treatment. Patients started recovering. And interleukin 8 by day 7 of the treatment. P-values are all significant. And lower incidence of post-acute sequelae of COVID-19. So long COVID was also reduced in the intervention group, in the group that was receiving medicines. 23 serious adverse events occurred in the standard care arm. Serious adverse, some side effects of the drugs or whatever was the reason. They occur while 1 serious adverse event was reported in the fluvoxamine arm. And 0 serious events occurred in the other arms. Now here is the interpretation. Please remember, nobody died in any of the groups. So interpretation, they say, early treatment with these combinations among outpatients diagnosed with COVID-19, the outpatient, was associated with lower likelihood of clinical deterioration and with significant and rapid reduction in viral load and serum cytokines, and with lower burden of long COVID. So less deterioration, lower viral load, lower cytokine storm producing cytokines, less long COVID. When started very soon after symptom onset, these repurposed drugs have high potential to prevent clinical deterioration and death in vaccinated and unvaccinated individuals. This is what is interesting. So my friend Jean pointed it out, that there is nobody who died. So when nobody died, then interpreting this data to say death prevention can occur or there is a high potential for that, that is an interpretation, correct, but that is not data driven. That can be driven from this point of view that, all right, there was less viral load, the cytokine storm was reducing, so patient really didn't have a chance to become serious. So of course, if they would not become serious, they would not die of COVID. Agreed, but at least the data itself, there was no death in any of the groups. So data doesn't show any data or any pointers for death. So that is the only one interesting critique of this study. So I want to just, before closing, just read once more the difference in the standard care and the other arm. In the intervention arm, the drugs, no participants had clinical deterioration by day 9, 14, or 28 days. Among those treated with fluvoxamine plus bromhexin, 0% patients deteriorated. Fluvoxamine plus cyproheptadine, 0% deteriorated. Or nicotinamide plus bromhexin, 0% deteriorated. They started the drugs within the 48 hours of the start of the symptoms. Fluvoxamine alone had 5.6% deteriorate. And then now look at the standard care. In contrast, most standard care arm participant had clinical deterioration by 9, 14, and 28 days. By day 9, 32.7% of patients in the standard care arm had been hospitalized without requiring supplemental oxygen, but needing ongoing medical care. By day 28, this percentage increased to 37.5%. Additionally, 20.8% of patients in the standard care arm required low flow oxygen by day 9, and 12.5% needed non-invasive or mechanical ventilation by day 28. So meaning if the early intervention was not started, then all of them would have a similar outcome. They would have a likelihood of the same outcome. So this is the discussion, really interesting study. Look at the references and the links in the description of this video. Early intervention was helping, at least the studies show that. And so it just makes me wonder if these kind of interventions were more common, how much life saving would have been happening. And again, I'll wait for the critics to say this study is not great. If they would, we'll look into that once again. But in the meantime, thank you very much. Please like, subscribe, and share. And there are links in the description. Become part of Drbeen. That is how you can support this work. Or you can buy me a coffee or other things. This work, as much as it is free, producing this is not a free activity. So if you would like to support it, I would appreciate that. With this, thank you, and I would see you again. Bye for now.